Thank you all for coming. We have several other people that have registered, so I want to apologize in advance if we have a little bit of disruption as they come in. We're very, very blessed in this community to have a wonderful healthcare group of doctors and healthcare providers. And what we like to do when we have our lunch and learns here in the building is to give you an opportunity to learn from these wonderful providers and these wonderful doctors, because we're very conscious of the fact that there's a lot of information out there on the internet and on TV and magazines that talks about healthcare but isn't always accurate, and isn't always accurate particularly for you. So that's why one of the things that we do here at Cornerstone is try to make the expertise of our physicians available to you. And in these lunch and learn sessions, what we like to do is feature various topics that there's a lot of information out there about that may or may not be accurate. And so today, we're very, very lucky, because one of the benefits of living in the High Point community is that we have extremely good cancer care. And the cancer program that we have here in High Point is getting better and better all the time, as the physicians who are managing that program strive to make it state-of-the-art. One of the ways in which they are making it state-of-the-art and they are enhancing it is by introducing a new type of care for our cancer patients in this community. And today, we're privileged to have Dr. Marissa Cangin talk to us about creating excellence in cancer care, integrating psychosocial support for patient and loved ones. And I want to just give you a little bit of a background of Dr. Cangin, because she is extremely well trained and educated and experienced for this particular area of psychology. I'm going to give you a little bit of her. She's unfortunately quite modest, so I'm just going to go ahead and give you some of her her background, so that you can understand where she's coming from and why the presentation she's going to give us is going to be so valuable and informative today. Dr. Cangin is an undergraduate of Pennsylvania State University and State College, Pennsylvania, and she received her Doctor of Psychology from Immaculata University in Immaculata, PA. She served an internship at the Minnesota Neurorehabilitation Services for Adults with Post-Acute Traumatic and Acquired Brain Injury in Brainerd, Minnesota. She holds 2 fellowships, one a postdoctoral fellowship in HMO-based clinical psychology from Kaiser Permanente in Salem, Oregon, and a second in psychosocial oncology at Comprehensive Cancer Center at our local Wake Forest University Health Sciences in Winston-Salem. Dr. Cangin has a relatively new position with Cornerstone that she's going to be telling you about. She is our Director of Psychosocial and Oncology Services here at Cornerstone, and her reason for being is to provide psychological and support services for patients and their families who are being treated for cancer. So I'm going to let Dr. Cangin share with you the information she has today, and again, thank her very, very much for taking time from her busy schedule to share her experience with us.
Thank you, Pam, and thank you, everybody, for taking the time out of your day to come. Okay, so let's dive right in. My goals today, as you can see in the overview, is to orient you to my team and what we do, and so that's the support team. Define some key concepts, list common sources of distress for patients and loved ones, clarify my role and how I conceptualize or think about cases or the patients and people that we serve, and guide you in how to reach us and access our services. Okay? Please feel free to interrupt, ask questions at any time. I like interaction. It doesn't have to be lecture style, but I'm cool with that too. Okay, so I figured it would make sense to start by discussing health in general. And there are 2 contrasting views of health, one being the biomedical model, where the belief is that illness and injury are biological problems, and therefore only the physical self is to be treated when one is sick or ill. This is successful in situations like infectious disease, less effective in situations where there's lifestyle-related factors like heart disease and some cancers. Then there's the biopsychosocial model of health. And That's where the belief is that illness and injury have biological, which can include genetics, psychological or behavioral, which can include lifestyle, your coping style, how you respond to stress, and sociocultural components. So that can include your social support system, your family relationships, and your cultural beliefs. So in this case, diagnosis and treatment decisions should take into account all. And that's the model that we follow and tends to be the modern way of viewing health. And so we see health as not only related to genetics or biology, but attitudes, personality characteristics, your emotions, and some of the choices that you make, and exposure to bacteria. So I figured I'll move over and talk about psychosocial oncology, be more specific, and give you a little background of it. Cancer has been believed to be terminal illness. There was a lot of stigma with it. Even just 40 years ago, people were not informed of their diagnosis because of the stigma. And until recent decades, it wasn't even really discussed because there was so much shame involved, even if there was no known reason or one pinpointable way to identify why a person was diagnosed with cancer. And not surprisingly, many of you already are aware, there's stigma attached to mental illness and psychological concerns, even in the context of medical illness. So thanks to significant progress in biomedicine, cancer is not necessarily a death sentence. People are living with and beyond cancer now, and many define cancer as a chronic disease. But despite this progress, cancer is still often considered synonymous with death, pain, and suffering. The formal history of the field of psychosocial oncology dates back only to the 70s, so it's very young as a field. And this became a formal field when the public and the professional community started to acknowledge that cancer and its treatment has profound effects on many aspects of life. So we are no longer, as a medical community, focused only on extending life, but also improving that life and the quality of that life. Psychosocial care received increased attention after the Institute of Medicine, or you'll hear people say the IOM, their 2008 publication entitled Cancer Care for the Whole Patient, Meeting Psychosocial Health Needs. And so now psychosocial oncology is an international field. There are standards of care, there's screening and measurement, along with temperature, respiration, let's see, I can't memorize them all, but heart rate, blood pressure, and pain. Healthcare professionals recognize emotional stress now as a sixth vital sign in cancer care. There are professional organizations, accrediting bodies, scientific meetings, and journals just in the field of psychosocial oncology now. So we are here, and we are here to stay. So let's define psychosocial oncology. You may already have a clear picture of what it is, but if you want to take home definition, one slide worth, here it is. Integrated supportive services, the key word being support. When you think of integrated, think of people working together, being readily accessible to each other, aimed to help those impacted by cancer cope, manage the following aspects of cancer and its treatment. So there's the physical, psychological, spiritual, social, and financial. And the goal is to increase a sense of control, reduce distress and sense of isolation, and instill hope that one can improve their quality of life and achieve best outcomes. So what is distress? If that's one of our primary goals as a field, then what are we trying to reduce? Distress is an unpleasant emotional experience. So it doesn't feel good, is the simple definition. It is of a psychological, spiritual, and or social nature, and it interferes with the ability to cope with treatment, cancer and the treatment. It extends along a continuum. It can range from expected, quote unquote, normal reactions to the diagnosis or feelings of sadness, anxiety, or fear, but it can also extend to become disabling and includes depression, anxiety, or isolation. But the take home for distress is it doesn't feel good, it can be caused by many things, and it can be an expected reaction or worse. But either way, we want to help people to feel as least distressed as possible. Different publications have different data on the incidence of distress. This one's right in the middle. Some of them say up to 60% at some point, but I figured I'd pick the middle ground. About 40% of cancer patients report clinically significant distress at some point in their cancer journey. And when I say clinically significant, it means it's worth paying attention to, and it may be worth intervention. Unfortunately, distress often goes unrecognized and therefore untreated. So one study, as you can see here on the slide, it assessed oncologists' ability to identify depression and anxiety, and as you can see, only 17% of clinical anxiety and 6% of clinical depression were perceived as such by medical oncologists. And that's no surprise. They only have so much time and their training is limited to medical. Thankfully, I work among very compassionate colleagues that recognize the need for supportive care, and we pick up where they leave off. Early identification of distress and response is imperative, and integrated psychosocial support makes that possible. And there is some data that shows that improves outcomes and quality of life. So what's quality of life? A personal sense of well-being encompassing a multidimensional perspective. So again, includes physical, psychological, social, and spiritual dimensions or domains. Changes in one quality of life domain can disrupt or impact another domain. So for example, disruption in physical well-being due to uncontrolled symptoms can affect psychological or social well-being. Recently, I worked with a gentleman who was managing severe nausea, and that interrupted his ability to fall asleep and to stay asleep and feel rested. So he was unable to concentrate as well as he normally does. He felt like he wasn't coping with stress as well. He wasn't as patient. He was more irritable. And then when he was ready to go out to dinner that he had been looking forward to for a month, he declined and canceled at the last minute, one, because he was nauseous, but two, because he was exhausted and didn't really feel like being social. So you can imagine how they can feed each other in a not so positive way. And most importantly, quality of life is best defined from the patient or the person's perspective. And this is just a table that lays out the domains, and if you are measuring or assessing quality of life, then these are the areas that one might explore. So in psychological, you might ask about symptoms of depression, anxiety, or adjustment to illness. Social, your relationships, your libido, your social and leisure activities, what do you do for fun, your work, and your roles within the household. Those can be disrupted too, not surprisingly. Let's say somebody's the person that is in charge of the bills, and now getting chemotherapy, not concentrating as well, some cognitive or memory impairments that are expected. So that person might say, hey, maybe I shouldn't be in charge of this for now. So that's certainly worth exploring. And then of course, physical pain, mobility, the ability to get around, sleep, and then sexual functioning. Okay. So what we often see, this is not an exhaustive list, but I figured it's important to identify the cancer-related distress in those domains that we typically see. And so from an emotional standpoint, sense of isolation is common, anxieties and fears due to different reasons. Sadness, guilt, and grief, to name a few. Then some spiritual distress might be related to the why me questions or the why not me questions. I run the breast cancer support group once a month at the Hayworth Cancer Center. And we recently, unfortunately, a member passed away, and she was young and had young children. And so the sentiment in the group from some of the folks who had cancer maybe 10 plus years ago and don't have children was, why couldn't it have been me? Which is very sweet and thoughtful. And then they felt guilty for that. They're like, well, I don't want to die. And so it can create this kind of cluster of confusion and emotions that are overwhelming. Faith. Your relationship with God, sometimes that's disrupted. Sometimes people feel very betrayed, not just by their body, but by their God, and then they feel guilt for that. So that can be very distressing, understandably. And physical, side effects of treatment, to list a few: nausea, vomiting, appetite changes, unwanted weight loss. And some surgeries, unfortunately, particularly with head and neck cancers, can be quite disfiguring, and that has emotional implications as well, of course. And or radical mastectomy in female breast cancer, or even male breast cancer. It can change, your sense of self, your identity, and for women, your sense of femininity. I'm not even going to try. Femininity. Okay. Then there's practical concerns that can be distressing in the cancer realm. Financial, not surprisingly, some people have difficulty affording their co-pays for medications, their office visits, or even paying for the gas to get to and from their treatment. And then informational. Some people feel like no matter how much information you give them, they don't get it and they're not at peace with what's been shared with them, or they feel like they don't have enough information, or they're going online, and unfortunately, when a lot of people are online and they read those blogs, those are the folks who aren't feeling well, and so it's not necessarily representative, and you can get some really bad horror stories. So none of these are mutually exclusive, as you can imagine. There's a lot of overlap. I figured it would be worth mentioning what's often referred to as the 6 Ds. They're universal fears, particularly in newly diagnosed patients, but I suppose I would argue that these are universal fears for all people. And they include death, dependency, disfigurement, disability, disruption, and discomfort. Any questions or comments at this point? Okay, here we go. So screening is important, psychosocial screening. The early definition of screening were where attempts were made to identify patients who are at greatest risk for future distress and to intervene only with especially vulnerable folks. And this was in order to forestall difficulty and strengthen their capacity to cope. But now the current and more broad view is that all patients, I'm going to say, and loved ones or caregivers can benefit from some type of intervention, whether it's education, encouragement, reassurance. So it can be very straightforward and be delivered by front desk staff, or it can be highly specialized and delivered by clinicians. So I'm happy to introduce our integrated psychosocial oncology services. It began in July 2012, so it's in its infancy. Some of our team members actually didn't join the team until the end of August and even mid-September. So we've already made significant progress in this very short time, but it's also really good timing to introduce the team and let the community know that we're here and what we do. So I listed here our program goals. And one, not surprisingly, is to identify and reduce distress. We want to catch it early and respond as soon as possible. And that can help to prevent things from escalating to a crisis situation. And by that, we can enhance screening with the goal of catching it early. And the referral process, if we're triaging people to the appropriate provider, then they will be seen as quickly as possible, their needs will be addressed by the correct person, and they won't be kind of passed around. But there'll also be, the coordination among the team members and the communication so that we can also be as efficient as possible. The implications of improved screening and referral, of course, is the reduction of distress, but treatment compliance, satisfaction with care, and quality of life. Another goal is to normalize and destigmatize the discussion of emotions and coping. So one need not have a mental illness to see a psychologist, particularly in the cancer setting, and that's true in the general community too. I think we're coming a long way with reducing stigma as far as cancer and mental health. Together it's a difficult thing, but it's worth it. And the other risk is the other side of things, where someone might say, oh, well, if I had cancer, I'd be depressed too. But not then take the next step and say, well, what can we do for you? Because it's almost like expected and you deal with that type of thing. Orientation and education for patients, loved ones, and staff. So we want to introduce people to the cancer services, to the support team, familiarize them with the facilities, as well as let them know who we are, what our background is, and give them a little kind of snippet of the work we do, or nuggets of wisdom, as I like to say. If you spend enough time with me, you'll notice I love catchphrases, I love metaphors and cliches, so I apologize ahead of time. And then our last goal is to provide seamless care for patients receiving their cancer oncologic care, whether it's at Cornerstone or the Hayworth Cancer Center at High Point Regional. This is the slide that I'm most proud of because it's fun and colorful. So on the left, you'll see the core team, and you'll also notice at the top it says the oncology care team. So while I'm Director of Psychosocial Oncology Services, we pooled people and asked them both within the community and in general population who are not familiar with how they perceive, you know, if someone said, hey, we're going to make a referral to you to psychosocial services, they'd be like, psycho what? They're like, are you saying I'm psycho? So that didn't go well. And we wanted it to be kind of self-defining, non-stigmatizing, and very accessible. So we came up with Oncology Care Team, and CARE is an acronym for collaboration, advocacy, resources, and education. And that kind of sums it up. So on the left there, you'll see the core team, and these are the folks that are working together regularly, and we are close together both in our goals and aims, but also in proximity in our workspace so that we can access each other regularly. We have 2 health navigators. We have me, clinical psychologist. We have a chaplain, a social worker, a dietitian, and a pharmacist. And then the extended team is Cancer Fit staff, which is a physical exercise program specifically for cancer folks, yoga instructors, nurses, medical assistants, a genetic counselor, and that can extend, you know, to the valet parking person, attendant, the first person people see when they pull up, to the physicians, and then community support. So, and I put in parentheses GPS, and some of you may be familiar with the GPS program. It's a grant-funded program, brainchild of Dr. Chinnasamy, medical oncologist. If you are not familiar with it, please see me after because you're missing out. And then you can see there in the center is the liaison, our psychosocial oncology liaison, who helps to assign patients to the appropriate providers to enhance communication between and among Cornerstone and the Hayworth Cancer Center. So it doesn't matter who pays our paycheck. As far as the patient's concerned, we're all on the same team. And we like to provide the care at the patient's most convenient place and time as much as we can. So we'll see them in multiple settings: inpatient, outpatient, Premier, Hayworth Cancer Center. Some providers, maybe navigators, might be in the home, or social worker if there's some type of home health care being set up. I am excited that a couple of our team members are actually in the audience. I won't make you speak, but if you wouldn't mind just standing up and saying hi. Our registered dietitian, Erin Klein, is right here. Can you like zoom in to her? And then our liaison, Wendy Martin, is right there in the center, the blue. Okay. So the services provided by the core team are important for you to know, I imagine. And like I said, in multiple settings, whether it's in the community, inpatient or outpatient. But navigation, we have 2 health navigators who are trained in nursing, and they are assigned to newly diagnosed patients with site-specific cancers. So we have a lung cancer navigator and a breast cancer navigator. And they provide personalized guidance and support to help folks navigate the complex healthcare system and the cancer world, whether it's to help schedule their appointments to be most efficient. So let's say if they recognize the need for psychological services, the person's already there for a scan. If I'm available, I'll meet them when they're already there so they don't have to make a separate trip. So navigators help with that, and that's just one small example of what they do. Solution-focused psychotherapy for cancer-related distress. I bet you can guess who does that. Spiritual and existential and emotional support, and that can be myself or our chaplain. And advanced directives help in preparing them. We actually can get the papers notarized on site, whether it's the healthcare power of attorney or your living will. And then we offer practical and logistical assistance, whether it's application for disability, assistance with transportation, skilled nursing facility placement, or setting up home health care, of course, financial concerns. And that's made possible by community donations to our Loveline program. For some of you may have heard of that. And continued nutrition consultation, as well as chemotherapy preparation and education, and that is by our pharmacist. Did I forget to mention? I did not. Yeah, I said pharmacist, right? Okay. I don't want to forget anybody. They're all as important. Okay, and we also provide support groups. And we have some diagnosis-specific support groups, like the breast cancer support group and prostate, leukemia, lymphoma, myeloma. But we also have the general living with cancer support group, and we have more on the way. In November, Our dietitian Erin, along with our Cancer Fit staff Melissa, will be running a group that combines nutrition, exercise. They may have some demonstrations. There are 2 Mondays, first and third Monday of every month.
6 to 7 at night.
So that's a great group. We have a caregiver support group coming up. And we also are looking into bereavement and grief group, as well as a men's group, men's only group, because, you know, prostate's not the only type of cancer that men can get. And sometimes it's nice to have that energy, you know, testosterone. So, and I figured it's important to note here, psychosocial support is only helpful when it's available and desired. And it doesn't necessarily have to be desired, like if somebody says, hey, would you like to see our psychologist? You seem anxious, and maybe she can work with you to help cope and work through some of those things. The person might be like, that's good enough. That's willingness. So they don't have to say yes, because that, you know, that's not very common, and that might be a different concern. But it is now available. That's the most important part. So let's talk about coping. There is variability in how people respond to a diagnosis of cancer. And there are factors that can contribute to how one responds to the diagnosis, and that can certainly include the nature and quality of their support system, their individual coping skills, and the meaning that they assign to it. There's no one-size-fits-all for coping style. A lot of times people will come in and they might say, you know, I expected that if I was diagnosed with cancer that I would just, you know, unravel and be hysterically crying, and I felt numb. And another person might say, well, I thought that I'd deal with it a lot better, and I had a full-blown panic attack and thought I was having a heart attack. And they say, am I crazy? And I get that a lot. And there's no normal. It's like you handle it how you handle it. And I think that that's sometimes the most important work that we do, is to just let people feel safe sharing their feelings without feeling judged. And there is good news. Most people are quite resilient and do well with education and encouragement. And it's also important to mention that loved ones, particularly those who are caregivers, are at high risk of mood and anxiety disorders. So we are not here just for patients. We are here for all folks that are impacted by cancer, and that includes staff. So when to speak with your team? Because people might say, am I crazy? It's like, well, then how do I know when I should come see you and not? 1, are your symptoms debilitating? Is it interfering with functioning in any major area of your life? Whether it's your work, your relationships, or school, your roles within your household, anything like that. And is your distress clinically significant? Meaning, is it a problem for you? And maybe does it feel unmanageable, overwhelming, and you feel like it's something that you would like an outsider who's unbiased but has maybe seen this before, that you feel safe talking to. Let me give you an example. And I define problem because sometimes we just like assume that we're talking about the same thing, but that's not always the case. You know, if I say distress, one person might envision themselves like crying if they're distressed, another person might envision themselves in pain. So I just like to clarify definitions when I can. So here, a problem is a demanding life event for which an adaptive response is not immediately available. Okay? All right. So I want to differentiate, give an example, at least from the psychological perspective and specialty standpoint. There's a difference between being anxious about the unknown, wanting one's affairs to be in order, thinking about mortality, and being preoccupied with death or thinking about or planning to end one's life. The first 3 I listed, they are usually in proportion with circumstances. The last 2, preoccupation with death and kind of like not being able to get your mind off of it, or thinking about and planning and having intentions to end your life, serious, okay? Clinically significant. All right, so I'm going to get a little bit more specific and address psychological factors that warrant attention, although this may be true for some of the other folks that are on my team as well. Critical time points. So I listed crisis points, and for different people it could be different, but from a treatment standpoint, diagnosis, decision making about treatment, side effects during treatment, late effects after treatment, and recurrence, which by the way has been shown to be more distressing than even diagnosis for folks. Survivorship, which is a time where treatment ends. And there's a difference between the survivorship phase of treatment, when a person completes active treatment and sometimes experiences a lot of loss because they got used to having the team there. It's kind of like a safety net, and they formed strong bonds with some folks that they call chemo buddies and the nurses there. And then survivor is different from survivorship. Anyone diagnosed with cancer, whether it was yesterday or 20 years ago, is a survivor. Okay? And major life changes, whether it's a death in the family, job loss, relocation, and you might say marriage, but that's a fun, happy time. Yes, it is, we hope, but it's also really stressful. So we want to pay attention to any major life changes, even if they're very welcome and of your choosing. And I figured it's important to note here that, of course, depression or other psychological conditions warrant attention. Up to 70% of cancer patients experience depressive symptoms at some point in their journey. And it is quite difficult to diagnose because some of the symptoms, actually many of the symptoms, can be attributed to the disease itself or the treatment. And those might include appetite changes, fatigue, restlessness, or that agitation, that internal, we call it akathisia, and sleep problems. Concentration is another one. Did I say that one? The exceptions are depressed mood, anhedonia, which is loss of pleasure or interest in activities previously enjoyed, suicidal ideation, feelings of worthlessness or excessive guilt. If those exist, they cannot be accounted for by anything else. So those are the questions that I hone in on in the cancer setting, to be more specific. So my psychological approach is that I provide brief, solution-focused counseling with adults. So they're cancer specific. If somebody has a history of mental illness and it's being exacerbated by their treatment or it's interfering with their treatment, I'll work with them through that. But if they do want to engage in long-term psychotherapy or counseling, then I'll typically refer them out to somebody in the community because I'm only one person and I have to keep my caseload manageable. And after a month, I think our liaison could tell you that I would just be booked solid and I wouldn't be able to take new patients. So we had to develop a model and an approach that works for this realm. And I focus on the inherent strengths of people confronting serious illness, which are often forgotten when we're in times of crisis. We forget that we have coping skills that we do. We forget things that used to work for us. Sometimes we go into survival mode and we just focus on doing what we have to do, and all those other things like getting a massage, which I hope some of you are doing regularly, exercising, eating well, socializing, all those things that contribute to our mental wellness and our overall well-being. Sometimes we let those fall at the wayside and it's like, no, I don't need to do it. I just need to pay this bill, get to this appointment. And so sometimes time, compassion, reassurance, encouragement, and reminding them of their inherent strengths can be very powerful. And I also provide specific therapies, and here's one example to help people cope with phobias and anxiety related to cancer care. I worked with one woman who had claustrophobia, but it was indicated and strongly recommended by her team that she get an MRI. So we did some guided imagery and deep breathing techniques to help her manage that. And CBT stands for cognitive behavioral therapy, and that's one technique that's been shown, or as we say, empirically supported as a treatment for depression and anxiety in cancer patients. My approach includes collaboration, focused on the whole person, not surprisingly. I encourage the patient to be an empowered self-advocate, to be the team leader. You have your healthcare team, you have your family team, and you are the leader of both. And I encourage healthy living, self-care, risk averting, keeping vices to a minimum. And here's a catchphrase that I really like: shifting from surviving to thriving. And of course, I coordinate care and enhance communication with the healthcare teams as much as I possibly can too. And I added something here, I made a note. Finding a sense of meaning and hope is always possible, even in the final months, weeks, days, and hours of life. And some people say, how could you possibly find hope when I have hours left to live? Well, you can hope that your affairs are in order. You can hope that you die a dignified death. You can hope that you are not in pain. You can hope that conversations have been had that were worth having. There's always room for hope. And you can hope that you are at peace with wherever you are spiritually. Okay? Here's an acronym that I really like that I share with folks, and it's the FACES strategy. The F is for face, don't flee from stressors. Then there's alter perception, So instead of thinking in all or nothing and black and white terms, you may be thinking in more or less, okay? So that things aren't so extreme, because it's rare that things always happen a certain way or that it never goes well, although it feels that way. And when we catch ourselves using that language, that can have certainly implications on how we feel that we're coping in our emotional well-being. Cope actively. It's easy to feel victimized by cancer and, of course, betrayed by one's body. The risk is that a person takes a passive victim stance. So, and that's different from saying, I'm fine, I'm great, I'm empowered. I mean, you can still have times of vulnerability. I just mean that you are not denying the reality either. But it doesn't mean that you're thinking about it always and therefore consumed by it. So it's all about balance, really, and everybody's different in their balance. And what works for one person might not for another. And what works for one person one day might not work for them an hour later. So it's a moving target. And that's what makes it a little more complicated, because humans are complicated, which is why they're so interesting. Okay, express emotions as opposed to put on a happy face. It's important to search for positive where possible, like resetting priorities or if you can find new learning. But feigning a positive attitude is a source of distress, so I wouldn't encourage that either. Seek social support. Support in any form allows you to express your emotions openly, develop coping skills, and studies have found that support group participants actually have an improved quality of life, including better sleep and appetite. And some people prefer online support communities, and they're plentiful, they're free of charge. If you aren't as mobile or able to ambulate back and forth or don't have the money for gas, that's an option. Or if you feel anxious in a group setting, so that's an option too. And then you'll see I gave you handouts. If anybody doesn't have them, then I will get them to you. Got it. All right. So there's 4 listed, but there's 3 total. Well, the slides are 1, so that makes 4. The oncology care team, there's an overview page there, and it lists the folks, what we do, our titles, and just a brief snippet. So this is kind of like the precursor to a brochure. And if it was up to me, we'd have headshots up there and team shots and doing funny things like this. And so there's that, and so you can learn the folks' name. At the bottom there, it has Wendy listed, our liaison. So if you have any specific questions or any more information that you would like from us, then please feel free to contact Wendy. The next handout is a front and back sheet, the Patient Orientation and Education Series. And that's the one I referenced that we do at the Resource Center at the Hayworth Cancer Center in the conference room there. And so if you pull up, the valet will take your car and park it for if you want, or park in the garage. But then when you walk in, the resource room's right there on the left, and that conference room's right there on the right there when you walk in. I hope I explained that clearly, but you can't miss it. And you can ask anybody. They are very helpful down there. So you'll see we run these series Monday to Thursday in 2-hour blocks. We each have 15 minutes where we introduce ourselves and give a little, like I said earlier, nugget of wisdom if we can. And on the back is the schedule with the topics on it. So I encourage all of you to come and tell everyone you know, and let them know it's free of charge and you don't need to register, you just show up. The next handout is on one side it says when to request an oncology care team consult. Some people, like to be prompted by questions, so here's a bunch of them for you if that's the case. And if any of these apply to you or somebody that you love or know, then there's your reason for referral. And Wendy's number's at the bottom, and that can be for anybody, whether it's our social worker, for me, or our dietitian. Let's see, and then on the back of that, I figured I'd give you a take-home coping with uncertainty and fear to feel more hopeful. That comes up a lot, the uncertainty and the fear associated with that. So hopefully there's something on here that you can take away, whether it's useful for you or somebody that you care about or are working with yourself. And I think that might be it. I appreciate your time and your attention. I'm humbled every day and inspired by the people that I meet, and sometimes I feel like I learn more than I teach or than I can even give, and it helps me to appreciate what I have and to keep my priorities straight and to keep me honest. And I wouldn't want to do anything else with my time. So I really appreciate your time, your attention, and I hope that this has been useful for you. Okay. Any questions? Thank you.
I want to say thank you so very much to Dr. Cangin and to her team. This is a unique opportunity that we now have in our community for cancer patients and their families to benefit from the group approach that has been proven in the more advanced programs across the country to be extremely effective. And a lot of these are issues that have never been really addressed before. And I don't know about you, but I learned quite a bit, and I'm very appreciative of this information because I think, we all know people in our lives that have been touched by cancer, and to be able to share this information with them if they're unaware of the attention that's being given to the psychological and emotional concerns, I think it's extremely valuable to be able to share that with them and to look up the resources that are available right here in our community. Again, I want to thank you all for coming. I want to very much thank Dr. Cangin. Her commitment to what she does and her passion is incomparable, and I'm just very, very pleased that she's taken the time from her busy schedule to share what we have today. We are going to, for the benefit of your folks that that may not be here or were not able to gather this information today, we will be posting this video on the Cornerstone website in a couple weeks. Generally, it takes us 2 weeks to get it back from the producers and then get it on. So please keep your eye on that. We put it on the About Us page, and we'll also have it on the page for Emerywood Hematology and Oncology, where Dr. Cangin's bio information is found. So please feel free to keep that in mind. And I also wanted to just let you know that we will have a lunch and learn next month, which will be about diabetes. And we have an endocrinology practice here in this building, and Dr. William Smith, who is one of our specialists, will be talking about the latest diagnostic and treatment procedures for diabetes. We encourage you to come. We encourage you in the medical community to tell your patients, and we encourage you from the community to reach out to folks that you may know that are struggling with diabetes right now, or just seeking more information that's not a bunch of hooey off the internet. In any case, we thank you again for your time and attention. I know Dr. Cangin is available for a few minutes, and certainly you'll have plenty of contact information to get in touch with Wendy and reach her if you would like to speak with her. And thank you for Erin and Wendy for coming today. We really appreciate what you do for this program. And again, thank you so very much, Dr. Cangin.
Again, and I keep telling her, stop lying, tell them the truth. If they say, how are you, and you feel like crap, you tell them you feel like crap. She won't do it. She'll lie to everybody, including you.
Are you asking her to be somebody she's not? Is this new, or is this her kind of personality style?
Huh?
Is this new, or is this this pre-existing personality?
No, she was always very honest, and she didn't like anybody. Like if I was sick, and she said, "How are you feeling?" and I said, "Well, I feel good." She'd about beat my head in because I lied to her. But now she's doing it to everybody she meets, and I just can't get her to, I don't know. It's like she pumped herself up. I was feeling great. Then we walk inside the door of the house, and then she collapses because she feels like crap. And I just can't get her to be honest with anybody, especially the kids. But she feels like crap. She needs to tell them. She feels terrible.
Does she?
Does she what?
Need to tell them?
Why not? They're adults.
Yeah.
And they, and like, so she's telling me she feels great. They don't think they have to help her do anything.
Sure.
They go on about their merry way.
Well, I actually do hear this a lot. And like we said earlier, cancer can take away a person's sense of control. So sometimes they will find other ways to re-empower themselves. And withholding information is one very powerful way to do that. And maybe in those moments when she feels great and is reporting that she's trying to convince herself of that too. Or maybe she is feeling great in that moment, but using up energy that she doesn't have and therefore crashing. I can't assume. But what you're bringing up comes up very frequently, particularly loved ones, spouses, and this shows why the upcoming caregiver support would probably be very useful for you. And then of course it would be up to her to seek her own support if she's willing and, to follow through with that. Sounds like you passed the baton.
Something you said about one of those programs that doctor, foreign doctor, we don't know about it. Was GP something like that?
Yes, GPS. The GPS, it stands for Guidepost of Strength. You do know about it? Okay. And if you have internet access, then all you need to know is cancergps.org. And it'll give you background information. There's a calendar of community events. They offer free events. Some of them are educational. Some of them are just fun and leisure. And but all of them are free of charge and put together by volunteers, many of which, if not all, are survivors themselves. And they're very passionate what they do. And I see them as kind of in the middle. They're not necessarily quite the extended team. They're not on our core team, but they are #1 allies in the community as far as support. So yeah, I'm glad you brought it up.
I don't have a question for them. I just wanted to say I do appreciate coming to these meetings and the cancer programs they've had. They have really been very encouraging. My husband's one has cancer, but it's a support system. And it really helps because I've met a lot of people, and I've met some who didn't have much family or didn't have any friends. And this has been a great source to help them. And what really helped me is my friends and my family. Because when we worship that, when they found out, all of them were so encouraging and supportive and caring. That made all the difference in the world.
Go ahead.
So I encourage everybody else to keep going to support groups because it really does help. Because some people are by themselves or they're lonely, and then anybody there can be a source of encouragement to them.
Yeah. Yeah.
And when somebody said, I understand, only a cancer patient could understand. They don't really understand. When they say they understand, at the support group, they understand.
That's a good point. I've never seen a closer knit community or bonds form as quickly as they do in the cancer community elsewhere. As soon as you say I'm a survivor, it doesn't matter what the cancer was, there's this camaraderie, there's compassion, warmth, and welcoming, and it's wonderful. And you're right, and feeling understood, feeling heard, feeling safe, and there's nothing like it. Nothing compares, and those support groups do provide that. All right, well, enjoy this nice weather. Thank you for taking the time and giving me your attention today. Take care.